Morning, everybody. I'd like to welcome you all to the February edition of the Shanks and Pathological Society Pathology Grand Rounds. We will have a talk for 45 minutes, followed by questions and answers afterwards. So please do feel free to type your questions into the Q&A box at the bottom of your screens. Now, it gives me great pleasure today to welcome our speaker, who is Dr. Jan van der Thüsenr, who is a histopathologist with subspecialist interests in thoracic and cardiovascular pathology. Jan received his medical training at the Universities of Cambridge and Imperial College London, and his specialist training at Leiden University Medical Centre. His PhD was awarded by Leiden University for his research into gene therapeutic approaches to atherosclerosis. He developed his subspecialist interest in thoracic pathology during appointments as consultant histopathologist and university lecturer at the Academic Medical Centre in Amsterdam and the Royal Brompton and Harefield Hospital in London. Jan currently works as the lead thoracic pathologist at the Erasmus Medical Centre in Rotterdam, where his research interests include the pathology of neoplastic diseases of the lung and mediastinum, fibrotic lung disease, as well as the pathology of pulmonary and cardiac transplantation. He is the president of the British division of the International Academy of Pathology. So today, Jan is going to give us his lecture entitled "The Little Things Are Infinitely the Most Important, Harnessing the Power of Biopsies in Lung Cancer." Thank you very much, Jan, for speaking this morning. Thank you.
Thank you very much, Mark, for that very kind introduction. And I'm very happy to be with you this morning to talk about what we have been researching in small biopsy specimens from the lung. And that also is reflected in the title, as just introduced. The little things are infinitely the most important. Well, our hospital certainly isn't little anymore. This is where we're based in Rotterdam. It's in fact the largest single academic hospital in the Netherlands. On the left-hand side, you can see one of our outpatient areas, and on the right-hand side, you can see our trainees, pathologists, and pathologist assistants hard at work. So, as you might imagine, this was not my quote, but in fact, it was a quote by Arthur Conan Doyle. Some of you may know this quote. It's long been an axiom of mine that the little things are infinitely the most important. Of course, this is something that you might imagine Sherlock Holmes saying in one of his cases. And it used to be relatively simple when it comes to the lung. So until the 1500s, we knew very little of the internal organs of the body, apart from some studies earlier also by Galen. And then in the 1500s, particularly Andreas Vesalius gained a lot of information from dissections, and he first described the differences between mass lesions and the absence of mass lesions in lung disease. Then in the 19th century, early in the 19th century, Laennec described neoplastic disorders and distinguished those from infections when it comes to mass lesions in the lung. And it wasn't until the advent of Rudolf Virchow and his microscopic studies in the lung that we realized that there were malignant and benign counterparts in tumors of the lung. And then it took over 100 years for us to have to make the distinction between a non-small cell and a small cell carcinoma of the lung, because in the 70s, it was apparent that patients with metastatic disease needed different types of chemotherapy depending on the histotype. And it wasn't until the early 2000s that we then had to decide whether a non-small cell carcinoma was an adenocarcinoma or a non-adenocarcinoma, squamous cell carcinoma, for instance, because these adenocarcinomas have mutations which can be targeted directly by tyrosine kinase inhibition. And then about 15 years ago, the IASLC produced a paper in which the various different subtypes of adenocarcinoma were described. And in fact, these are also subtypes that we are requested to report today, and the significance thereof I'll explain later on. So when it comes to a stage 4 targeted therapy in non-squamous cell carcinoma, this is informed by a large range of different genomic alterations, going from the archetypal EGFR mutation and KRAS mutations all the way through to rarer mutations such as HER2 mutations, NTRK fusions, ROS rearrangements, etc., etc. So there's a whole host of these which are now targetable and are responsive to the respective inhibitors. This is also reflected in the ESMO guideline, where the various mutations that we need to test for in stage 4 non-small cell carcinoma or non-squamous cell carcinoma are listed. And in fact, we are producing a new or an update of this guideline at the moment, so stay tuned for the new guideline. Although I think when it comes to the number and the type of different targets that we need to test for, this will not change very much. We use all sorts of different specimens to perform this type of testing, and that's usually done by next generation sequencing nowadays. And that goes from cytological specimens, as you can see here, to larger biopsies. But on the whole, we're dealing with very small amounts of tissue. So I think we have to realize that this tissue is very valuable when it comes to the DNA and the RNA content, and it should also be treated as such. So the procedures in our laboratory are gauged towards preserving the tissue as much as possible and actually also producing as much DNA and RNA as possible. Then this would lend itself to next generation sequencing, and then of course the sequence determines whether a mutation has taken place. To do this, in small specimens, we perform microdissection. Sometimes, if necessary, this can also be done by laser capture microdissection, just to enrich the number of tumor cells within the material to make sure that NGS is successful. Now, something that has come to the forefront in lung oncology are new technologies for acquiring this type of material. Many of these are not transthoracic anymore, so we're used to receiving transthoracic needle biopsies. This can be detrimental to the patient because these patients can then develop pneumothoraces, for instance, or pain, and therefore bronchoscopic approaches are now preferred. One of the new kids on the block, as it were, is the navigational bronchoscopy, whereby imaging can actually tell the operator where the tip of the probe is located, and thereby affording much more control over the area which is biopsied. That leads to, in our experience, also smaller biopsies compared to the CT-guided biopsies, and also sometimes only cytological specimens, which are informative. This necessitates the assessment of these types of specimens for adequacy, also in these hybrid OR theatres, operating theatres, where most of these techniques are done, because it's a huge time investment. Some of these patients spend a couple of hours or perhaps more in these theatres being investigated, and you want to make sure that's first time right. Now, one technology that we've also evaluated, and I've been involved in some of these studies, also coming out of Amsterdam, where we compared the histology after routine embedding and H&E staining to so-called higher harmonic generation imaging, which is a laser-based technique which combines three different techniques. One is the two-photon excitation autofluorescence, which mainly stains elastin. Then there's a second harmonic generation, which nicely stains collagen, and third harmonic generation, which is particularly useful to detect cell structures. If you combine that, that gives you this very pretty, colorful spectrum of different components of the biopsy. Not only does it look very nice, it's also quite useful in producing an immediate image within minutes of hopefully the representativeness of these biopsies. You can detect normal tissue, as you can see here, with the stroma underlying the basement membrane, with the surface epithelium, which looks to all intents and purposes normal. You can even see the cilia at the surface of the epithelium. You can detect areas of squamous cell metaplasia, as you can see here in C and D. in the middle section, and then at the bottom you can actually also determine areas of fibrosis, particularly elastosis, will show up as this very purple area here. But it is also useful in detecting malignant cells. You can appreciate the enlarged nuclei here on the right-hand side in this non-small cell carcinoma. Also in the middle, you can see that here. So you have an adenocarcinoma, squamous cell carcinoma. Here at the bottom, there's a typical carcinoid. Perhaps these little specks that come up in the third harmonic are also representative of neuroendocrine vacuoles, and the nuclei are much less atypical than those in a carcinoma. So I think this is already very useful in determining, of course, a representativeness, but potentially even making an initial stab at a diagnosis. You can use these images also for morphometry. We've done so looking at, for instance, the cell nucleus diameter in relation to the diagnosis. As you would expect, carcinomas tend to have a larger cell diameter. You can also appreciate these nucleoli in the nuclei here on the left-hand side, and very much less atypical nuclei in the carcinoid. Perhaps we're not able to extract all of these features adequately at this stage, and we might be able to use AI to correlate with the eventual outcome. So here we have 69 biopsies, some of them classed as non-malignant, some as malignant, and then you can train the model to actually recognize the presence of malignancy within these sort of images, giving quite a nice AUC here for these initial results. So I think this can be very useful. I think we need a lot more training. We also need to train on a large variety of different specimens, so the model doesn't get confused when it sees something it hasn't been exposed to before. But I think this is probably going to be very helpful in the hybrid OR, where there may not always be a pathologist present to do the initial analysis. And the next step might even be to also incorporate the CT image, perhaps also the thoracoscopic camera image, and the on-site higher harmonic generation, as well as potentially even the histology image, to produce models which can predict, for instance, prognosis or outcome to therapy. Now, in addition to molecular diagnostics, of course, PD-L1 staining has become very important in the field of non-small cell lung cancer, because this is so far the only biomarker in routine use which predicts response to PD-1, PD-L1 blockade. As most of you will know, and this is a very simplified version, of course, the T cell is activated by connection with the antigen on the tumor cell, or an antigen presenting cell, or an MHC that's presented. You get the interaction here, which activates the T cell. And there's also a break, there are many breaks, in fact, but one of these breaks is the interaction between PD-L1 on the tumor cell, or the antigen presenting cell, and PD-1 on the T cell, which makes the T cell anergic. So you want to break that break to actually afford anti-tumor immunity by your own T cells. And that's done by immunotherapy. Now, PD-L1 is not a perfect biomarker. We know this. The cutoff for various studies is, on the whole, 1% or 50%. But you can appreciate that the overall response rate in treated patients still increases above 50%. And even in those which have a PD-L1 expression of less than 1%, some of these patients still respond, as you would expect from a continuous biomarker. So I think we're missing some information there. The other problem is that tumors can be quite heterogeneous in their expression of PD-L1. So some tumors, and you can see that here, have very sharply demarcated areas of zero expression of PD-L1 versus complete or 100% expression. So you can imagine that if you biopsy a tumor from the left-hand side, you will end up with a very low expression, and on the right-hand side, you will have high expression, thereby qualifying this patient for immunotherapy. So there is a risk of a sampling error there. Now, to address the PD-L1 or the suitability of PD-L1 as a biomarker for immunotherapy, you may also use AI approaches, which is something that we've also done. So we've built a model to score PD-L1. And one of the problems is that we have considerable inter-observer variability between pathologists when it comes to scoring these sort of specimens for the 1% cutoff, for instance, or the 50% cutoff with kappas between 0.4 to 0.9 and respectively 0.3 to 0.95. So I think this is something that we also need to appreciate, that as pathologists, of course, we also have a human factor. And in fact, we've done a study looking at exactly this and linking PD-L1 scoring to the personality characteristics of the observers or the pathologists, and there is quite a strong correlation. So we have to remember that we're all humans, and that maybe sometimes a machine can give you a more objective response or a more objective assessment. Now, one of the problems is that PD-L1 is also strongly positive in macrophages and immune cells, which we usually don't score for in non-small cell lung cancer. Here on the right-hand side, you can appreciate all of these alveolar macrophages being strongly positive, whereas the normal epithelial cells surrounding them are negative. Then here on the left-hand side, there's a lymph node with a lot of expression in immune cells and in macrophages. The intensity of staining can be a problem. It's sometimes difficult to appreciate. Here on the left-hand side, it's not very difficult. So very strongly positive. Here on the right-hand side, there's very faint staining, but even the faint staining is seen as positive in the method that we use in the lung at this stage. So you shouldn't miss this. And I think sometimes it can be difficult to assess this, even in small biopsies. And then there's another problem with being close to the cutoffs. So if you're close to the 1% cutoff or to the 50% cutoff, I cannot honestly say that in a larger specimen, I can tell whether a tumor that's around the 50% mark is definitely 49 or 51%. I think an algorithm could do that. Whether that is absolutely necessary is also a question, but it has effect on, for instance, reimbursement of immunotherapy in these patients. So I think that is important to bear in mind. So what we developed is a system of automated whole slide PD-L1 scoring, which we intended to be similar or better than pathologists when it comes to performance, and it should be suitable for daily clinical practice cases. So everything that we do is always aimed at producing something that is useful in clinical practice when it comes to research in this type of material. And so we did a study in which we had a group of pathologists scoring PD-L1 and comparing that to the average score, and the overall agreement of the pathologist was actually quite good when it came to the 1% and the 50% cutoff, but the AI validation was at least as good, particularly when it came to the 50% cutoff. It probably also outperformed the pathologists. And that's what I mentioned. It's very difficult to make that distinction between 45 or 55%, for instance, for the human eye. Another problem with PD-L1 is that it is only one of the various components of the sort of biomarker spectrum that determine response to immunotherapy. So the absence of checkpoints, so PD-L1 expression may lead to resistance to immunotherapy. But in the tumor, you can also determine the mutational load, and we know that this tends to be quite high in non-small cell carcinoma of the lung, and that it can correlate with response to immunotherapy because of the immune system recognizing this tumor foreignness. The infiltration by immune cells, which then eventually are the effector cells of the anti-tumor response, can be important, and also the expression of, for instance, MHC, which presents the antigen to these T cells, can be of importance, as well as, for instance, interferon gamma activity within the cells, which also has a role in this presentation. Now, there are other soluble factors or circulating lymphocytes, which you could also investigate, but I consider those to be sort of out of the realm of what we do in pathology. So we've taken all of these 4 components and tried to assess those in a study of non-small cell lung cancer biopsies. The premise was that a combination of biomarkers would give a more accurate prediction of response than PD-L1 expression alone. Yes, of course, we only get tiny biopsies on the whole, of which only a part usually is still a non-small cell lung cancer. So you need to determine this in very small biopsies. And we wanted to know whether determining these 4 biomarkers in a single small biopsy would already have predictive value, because many of the studies that have been done regarding this were done in resection specimens. Of course, there you would have much more material to work with. So this was a proof of concept retrospective study looking at the feasibility of assessment in small biopsies of these parameters. So we had 30 cases from the Multimab trial, which was an early nivolumab trial in non-small cell lung cancer. We determined the tumor mutational load through a standard next generation sequencing panel that contained 409 cancer-related genes. And then we performed immunohistochemistry for PD-L1, CD8, and HLA class 1, and correlated all of these biomarkers separately with response. And here you can see the progression-free survival on the left and the overall survival on the right, as you would expect, differentiating by strata of less than 50 and more than 50% of PD-L1 delivers a stratification in response. Interestingly, as perhaps we also expected, the PD-L1 expression is not one-to-one linked with the chance of response. So you can see here that many of the patients who have 0 PD-L1 expression still show some degree of overall survival benefit when it comes to immunotherapy, and even some progression-free survival benefit. So we're missing something, as we were expecting. The tumor mutational load was also correlated with survival. The higher it was, the better. So over 10, that was the cutoff. We saw a definite survival benefit. CD8 seemed to be important, particularly in progression-free survival, and HLA by itself didn't seem to have much of an effect. But if you take everything together, the 4 biomarkers, and then you cluster these cases, you can derive 4 different clusters, of which one, which is the 1B cluster, which has particularly high expression of PD-L1 and also a high tumor mutational load, has a better progression-free survival and overall survival. So I think even in small biopsies, you can have this sort of approach. It's probably not as robust as it would be in resection specimens. I think this is something to be explored further. And here we can see 2 cases, exemplary cases here on the left-hand side. Although this patient had a high tumor mutational load, there was very little expression of CD8, HLA-A or HLA-B or C, whereas here on the right-hand side, you can see PD-L1 expression, CD8 expression, and also type 1 MHC expression. So this patient had a good response, partial regression, in fact. Now, systemic therapy in non-small cell lung cancer is also moving into the early stage arena. So prior to this, we usually got a diagnostic biopsy and then a surgical resection. All we had to do is assess the resection specimen, of course, according to the TNM staging, to provide a rationale for potentially adjuvant treatment with chemotherapy or radiotherapy, and also to provide prognostic information. Nowadays, we also have neoadjuvant therapy prior to surgical resection. For nivolumab with chemotherapy, we need an expression of 1% of PD-L1 and no EGFR or ALK alterations, and we also assess response then after surgical resection. Another option is to give adjuvant therapy. In the Netherlands, we can use atezolizumab with PD-L1 expression of 50% or higher, and again, no EGFR or ALK alterations. And potentially, we're now also moving into an era of perioperative therapy where you would get chemoimmunotherapy in the neoadjuvant setting, and then the mono immunotherapy, for instance, pembro, in the adjuvant setting. So it's a 2-stage therapy, really. This is an exemplary non-small cell lung cancer patient. She had previous oropharyngeal squamous cell carcinoma, and now there was a non-small cell lung cancer in the lingula and also positive lymph nodes. This was a needle biopsy of the smallest lesion, and we saw lung adenocarcinoma with cribriform and solid growth pattern, KRAS and STK11 mutations, and a low PD-L1 expression, which was started on chemo immuno neoadjuvantly. And of course, in this biopsy, you can already see a wealth of data. So you can see the tumor, you can appreciate the stroma, you can appreciate the immune infiltrate. You can, of course, assess with immunohistochemistry, you can do molecular diagnostics. So there's a wealth of data that can determine the prognosis, which can be important potentially in early stage tumors, which have a high risk, and can also be predictive to perhaps de-escalate therapy in the adjuvant setting or switch adjuvant therapy. Now, something that I previously mentioned is the adenocarcinoma classification that's been around for a while, and this can actually be very helpful in determining prognosis of these patients. We have various invasive growth patterns. So one of the commonest ones is the acinar growth pattern, where the adenocarcinoma cells grow in these glandular structures, as you can see here on the right-hand side. And in fact, here at the top, it's the lipidic pattern, which is an in situ type pattern. Then we have other invasive patterns such as papillary, which are these fibrovascular cores covered by malignant cells, micropapillary lacking fibrovascular cores, and then the solid pattern. And the current recommendation is that we report all of these, and particularly also mention the predominant subtype and describe the individual components in a semi-quantitative manner to the nearest 5%. But this is done in resection specimens. Now, in the era of neoadjuvant therapy, we will often see a very good response of the tumor to that neoadjuvant therapy. So it's very difficult to actually determine this in the resection specimen. So does this lead to significant prognostic stratification in resection specimens? Yes, it does. So we know that tumors which are completely in situ or minimally invasive tend to have a very good survival. In fact, 100% disease-free survival in this admittedly very small cohort of 5 years. And then the intermediate grade, you can see the survival drop, and particularly the high grade, which are especially the micropapillary and the solids, tend to have a lower survival. And this is now also reflected in the WHO classification. So the grade 1 are the tumors with less than 20% high grade pattern, lipidic predominant. Grade 2 are moderately differentiated, so that's acinar papillary predominant with no or less than 20% high grade pattern. And grade 3 is any tumor which has 20% or higher high grade pattern. So that is a micropapillary, solid, cribriform, and complex glandular patterns. Now, that is also reflected again in a probability of disease-free survival after surgery. So it's good to know that this works. We don't use it to that extent yet in clinical practice, which I think is probably a shame, and I'll go into that a little bit later. So the prognostic relevance of the predominant pattern has been shown, particularly for the micropapillary and the solid, as you can see here, in terms of disease-free survival, but also the subpattern, even with a tiny component of micropapillary, you already have a poorer outcome. So I think it's these high-grade patterns that we should be focusing on. And it's the micropapillary pattern which leads to early lymphovascular invasion and early lymph node metastasis, and therefore to recurrence of disease. Now, it's probably also linked to something that we now term spread through air spaces, where a sort of micropapillary pattern is seen beyond the edge of the tumor. And this has been found to be correlated with a poorer outcome in stage 1 non-small cell lung cancer. And we've recently done a study with the Pathology Committee of the International Association for the Study of Lung Cancer, ISLC, looking at the so-called JCOG trial out of Japan, which is an early stage surgical trial. And STAS was in fact detected in about a third of cases, which is consistent with previous studies and is linked to relapse-free survival and overall survival. And it was also correlated with histological grade 3, as you might imagine. So I think there is a link between STAS and grade 3. So the biopsies which have that high grade 3 pattern are more likely to, if you then receive the resection specimen, also to have STAS in the vicinity. So you could potentially use that high-grade pattern as a surrogate for STAS, or the other way around, in fact. Something similar also happens in squamous cell carcinoma. This is a study that I've also been involved in with the ISLC, looking at tumor budding in squamous cell carcinoma, and that also seems to be correlated with recurrence-free survival and overall survival. And in fact, this turned out to be probably the only really prognostic parameter worth scoring in squamous cell carcinoma. Now, we've previously also looked at mitotic rate in lung cancer, and there seems to be a correlation with survival probability if you stratify these patients into different mitotic counts. As you can see here, low 0 to 1 mitosis per 10 HbF, and 2 was defined as 2 to 4 per 10 HbF, and then 3, 5 or more. And if you then combine that also with the nuclear diameter, you can end up with an overall low or high risk score, and that is also, again, correlated with survival probability. So that's something that could also be scored potentially in biopsies. Now, if you overlay the survival probability difference onto grading systems that we routinely use, such as the Gleason grading system for prostate, you can see that it's at least as good as making the distinction between 4+3 and an 8 to 10 Gleason in prostate. It's probably also at least as good as the distinction between a low-grade and a high-grade breast carcinoma, according to the Nottingham score. So why we're not using this in clinical practice, I don't know. I think we need prospective studies in lung cancer like we have seen in the breast and in prostate. So how about using this in biopsies? We did a study at Erasmus a couple of years ago, looking at matched biopsy and resection specimens of adenocarcinoma, and then trying to find out whether you can score these tumors according to their growth pattern, and whether there is a correlation with the eventual resection specimen. And in fact, that seems to be the case both for the predominant pattern, so there seems to be a reasonably good correlation between the biopsy and a resection specimen, although some of the solids eventually turn out to be acinar, for instance, so there is some crossover between the groups, and there's particularly strong correlation also for the worst pattern seen in the biopsy, although admittedly we didn't see that many micropapillary patterns. But then if you look at the predictive capability of scoring for these patterns in biopsies versus resection specimens, it's particularly the poor patterns which have a very poor outcome if you detect those in the resection, in the biopsy specimen. So we're not as good as predicting from the resection specimen the patients which have a very good outcome, but we are very good at picking up those that will have a poor outcome. So I think that's the way that you can interpret these results, and the same actually also goes for the nuclear grade. So the biopsies are important in identifying high-risk patients. And you could use that in a flow chart where previously you would have to do frozen section analysis potentially in a resection specimen, but now you could possibly replace that by biopsy analysis prior to the surgery, and that would already determine whether you can do a sublobar resection or you would need to do a complete lobectomy in these patients, in early stage patients. So what about the elephant in the room? Also in this case, it's reproducibility. We know that the reproducibility is acceptable, but not great for all of these different patterns. We can see that residents after training often outperform pathologists with experience, with many years of experience, which is, I think, very encouraging for our young colleagues. But perhaps we could also replace pathologists altogether and use AI. So in this case, we've trained a model to recognize these high-grade patterns, so the micropapillary and the solid type pattern, which may be quite useful in a busy practice, just flagging these high-grade type of patterns to the reporting pathologist. We could also predict recurrence by just doing AI, so it's a so-called end-to-end model. So you do away with these growth patterns altogether, and you just train the algorithm. Here on the left-hand side, it's the pathologist, on the right-hand side, it's the algorithm. You can see that the algorithm actually outperforms the pathologist, both on a patch level, which are just small areas of the tumor, and on a patient level, where you take all of these patches together. So that may be the future. This also offers you a possibility of interpretability. So this model will look at features which we previously hadn't recognized, perhaps as being important for being correlated with prognosis. And you can do that from these sort of heat map renditions. Just a little bit of a switch to pulmonary neuroendocrine tumors. Again, we have different subtypes which have different outcomes. So typical carcinoids have a better outcome than atypical carcinoids, and particularly the large cell and small cell lung carcinomas with neuroendocrine features have a very poor outcome. And we routinely do this based on morphological criteria, such as the mitoses and the presence of necrosis. So this is, again, to some extent, I think, probably subjective and can lead to inter-observer variability. Now, in biopsies, if we don't see any mitoses and there is no necrosis, we're now by the WHO classification told to sign these out as carcinoid NOS, because we know that some of these cases, and we've done a study to this extent as well, that some of these cases, in fact, are then reclassified in the resection specimen as atypical carcinoid. So up to a quarter of these cases, and even if you score them as NOS, up to a quarter are also atypical carcinoid. So we're not very good at recognizing the potentially higher grade of carcinoid in biopsies. Now, we could use prognostic markers. We know that OTP and CD44 confer a better prognosis in low grade, but also in high grade neuroendocrine tumors. So if you lose either OTP or CD44, or potentially both, you tend to have a poorer prognosis. We have just started a national study in the Netherlands looking at staining for these markers in neuroendocrine tumors to determine whether patients are low risk or high risk, and also adding in Ki67 into this mix. So if any of these three don't meet the criteria, then the patient is classified as high risk. And these patients then go into a different arm of the study and will have less intensive follow-up after surgery. And potentially you could also use that in the pre-surgical setting to do this type of analysis on biopsies. And we've also trained some models on neuroendocrine tumors, looking, for instance, at predicting recurrence in carcinoid biopsy specimens. I won't go into the details, but we used TMAs to train the model, and then eventually tested this on real biopsy specimens and correlated that with outcome. So again, this was an end-to-end model, not looking at the classification. We obtained some pretty good, I think, AUCs for many of these different approaches, so the so-called folds of these models. And this is the sort of typical confusion matrix plot that you would see, or where you can see that the darker the color, the better the correlation between the AI prediction and the recurrence label. You can see that particularly in our own set, that seemed to work quite well, but also in the biopsy set with a paired resection diagnosis that we got later on, that worked quite well. And in this case, again, you can look at the explainability and see where the model made the right prediction and how it arrived at that prediction. And in fact, the cases that were incorrectly identified were focusing mainly also on stromal components. So that was surprising to us. So the stroma apparently is interpreted by the model as having a poor prognosis. Now, this is, I think, an important addition, because if you use this type of model, you can really reduce the number of false negatives, which is important in that type of study that we call the magnet study, in excluding patients from the intensive follow-up that they would normally receive. And this is both the case for those cases where only the biopsy was available, and also in the cases where we had the paired resection. Admittedly, you'll get a higher percentage of false positives. I think for screening, that wouldn't be necessarily a bad thing if you limit these patients to a less intensive follow-up. So in the magnet study, we're now also planning to run the AI model in parallel. And then lastly, the large cell neuroendocrine carcinoma tends to have a higher grade with necrosis, more atypical cells, lots of mitoses on the H&E, high proliferation rate in the Ki67, positive for CD56, synaptophysin, chromogranin, and TTF1, and recently also with the addition of NSEM1 as a neuroendocrine marker. And in the WHO classification, if we don't see any neuroendocrine morphology, we are not allowed to call this an LC-NEC. I think that's important because these patients, if it's a stage 4 disease patient, they will receive chemotherapy, and that may depend on whether you can identify that large cell neuroendocrine carcinoma as to which type of therapy that is. So I think it is important to be able to recognize this. And we know that from previous studies that we've done is looking at the correlation between the biopsy and resection diagnosis, that often cases of LC-NEC are not identified correctly in the biopsy specimen. So I think that is something to be aware of, and that led us to the so-called LEGO study, which again is a national study where we tried to determine whether having 2 or more neuroendocrine markers positive in biopsies can actually predict an LC-NEC diagnosis. Please excuse the Dutch. This is a study that's just closed, and we're doing the analysis at the moment, and hopefully very soon there will be a paper. So stay tuned to see whether this is actually the right approach or whether we might need to bring in the neuroendocrine morphology still. We could do also by predicting the outcome from just the H&E through training a model to see whether you can actually detect LC-NEC morphology in that. We also know that large cell neuroendocrine carcinomas and in a certain number of cases have loss of RB1 expression and RB1 mutations, and these patients can be assessed by immunohistochemistry. You can see that here at the top right-hand side, RB1 is lost, P16 is overexpressed, and they often have, and that's fairly non-specific, also P53 mutations. And these patients, you can see that here at the bottom right, tend to respond better to the small cell type chemotherapy than to large cell type chemotherapy. So it's important to know this molecular subclassification. And that's something that we've also trained an AI model to do, to look for features which predict whether a tumor has lost its RB1. And if you look at the tile-wise and the patient-wise stratification or classification, you can see that again, we reach pretty good AUCs of around 0.84, 0.85 for predicting the RB1 status. We can then feed that back to the pathologist to see whether we as pathologists could do the same. And we did that also on a set of small cell carcinomas. And in fact, those that were wrongly predicted as RB1 retained had more large cell-like morphology in their nuclei. And we told the pathologists this, and they had to look at the slides and determine whether these cases were RB1 positive or negative. So this is whether the model looked at these cases, and it's interesting to see that those that were classified as RB1 loss, the model was focusing mainly on the cytoplasm, whereas those that were classified as RB1 retained, the model was focusing on the nuclei, whereas those that were wrongly classified, it was a little bit all over the place, as you would expect. So it's not always right. And here we compared it to the pathologists and looking at where the pathologists went wrong. And in fact, the model did outperform the pathologists when it came to RB1 prediction, as you can also appreciate here in the spider plot. So that's the WHO classification, and the blue is the model. Okay, so this brings me to my final slide, and the question is AI a solution for classification? I think it is, as long as we understand what AI is doing for us. And I think as long as we use it to solve a clinical problem, and there are many of those in biopsy diagnosis in the lung, so I think we can definitely use its help. And then eventually we can learn to collaborate or perhaps even love each other. Then in summary, I would say that grading based on growth pattern remains an important prognostic factor in lung cancer, increasingly so perhaps as we go to early stage systemic treatment, still scored according to the WHO criteria. And in fact, the grading may also be introduced soon into the TNM classification. Pattern recognition is because of the stage 4 treatment, but mainly also because of the systemic treatment in surgical patients, important in biopsies. Inter-observer variability remains an issue for all of these assessments. AI may help us to distinguish these patterns. End-to-end AI, where you just link the morphology to the outcome, may be better in predicting outcome, and it can offer the advantage of interpretability and actually help us to gain insight into biological processes. And then predictive and prognostic immunohistochemical phenotyping remains, I think, important and can be an important addition. And of course, I wasn't able to do all of this by myself. So these are a few people I'd like to thank, so particularly our team from Erasmus, also from the Department of Pulmonary Oncology, Anne-Marie Dingemans and Jules Dirks, and the people I work with in Leiden, in Maastricht, Amsterdam, and then the funders, KWF, so that's a Dutch Cancer Foundation, and the Hanart Fund, which provides funds for AI research in pathology, and of course also the International Association for the Study of Lung Cancer. And I'd like to thank you for your attention today.
Thank you very much indeed, Jan. That was a really interesting talk, some fascinating data with a lot of thought-provoking material, questions and some answers, particularly the use of AI. Now, I'd like to encourage the audience to ask questions. Please type your questions into the Q&A box at the bottom of your screen, and I will read them out for Jan to answer. But if I could kick off, please, with the first question, Jan. Taking you back to near the start of your talk, when you're describing the HHG method, how are you using that? Are you using that in routine use? And is it possible to use it for some of the biomarkers you discussed, such as PD-L1, CD8, HLA, and so on?
Oh, yeah, those are two very good questions, Mark. So the first one we're trying to address, so we're currently embarked on the follow-up study, and that's being run out of Radboud University in Nijmegen. So that's where they're doing the technology, and I'm also involved in that research, and trying to find out what the added value would be in routine diagnostics. I think there will be definite benefits. I think that there's definitely also pitfalls. It's a different way of looking at tissue because you tend to squash the tissue a little bit more than you would do in a routine section. So there's a learning curve, and when I started off, I got it wrong quite frequently. So I think it's a different technology for us, and that's going to be very exciting. And the other thing is that what I mentioned about doing AI on these specimens, I think that would lend itself exactly to that type of question. You know, can you predict from just the HHG appearance whether a tumor has a high PD-L1 expression, for instance, and what the infiltration rate by lymphocytes is? Yeah, I think we're going to need some type of assistance when it comes to the visualization and analysis thereof, because I think this is beyond what we can do as humans.
Okay, good. Thank you. So switching to some of the questions in the Q&A box, Damien Amendra asks, just a technical question. When you clustered the samples based on old biomarkers, which clustering parameters did you use and why?
I guess that refers to the clustering on the PD-L1, TML, HLA expression, CD8.
Yes, probably. I think so.
Yeah, so I think we used the parameters that we would normally have used for standalone parameters. So, for instance, for TML, we had a cutoff of 10. For PD-L1, we used a cutoff of 50. And HLA, I think that was just on or off. You know, is there expression or not? And CD8, I'm not sure what the exact cutoff was, because I think there are various cutoffs out there at the moment, whether that's 25% of cells or 5% or 50%. I'm not sure. Yeah, I'd have to go back.
Okay, thank you. And the next question is from Ersin Spahik, who asks, in a predominantly lipidic lung adenocarcinoma, where the alveolar walls may appear thickened or irregular, how can true invasion be reliably identified?
Yes, that's a fantastic question, Ersin. This is something that we have been trying to address for a few years now, and also within the ISLC, because we know that is very important area of distinction, because that determines whether something is invasive versus, of course, still in situ. One of the tricks that you can use is using an elastin stain and see whether the pre-existing elastin of the alveolar walls is still intact. So that can be a way of looking for invasion. Another one is the production of endosmoplastic stroma. So sometimes you will see the elastin still in place, but then around these little epithelial structures, you will actually see a lot of endosmoplastic stroma. You can see that also in the EVG stain. And then I think the third one is that you look perhaps in a lower magnification at the organoid architecture. So if you lose your organoid architecture, I think that's when it becomes difficult. But I think it's particularly that's when it becomes malignant. Or invasive. So it's particularly the distinction actually between lipidic and papillary, which can be very difficult in this case, and not necessarily the acinar and lipidic.
Okay, thank you. So the next question is from our old friend Neil Shepherd, who asks, are pulmonary pathologists going to stop using the term carcinoid anytime soon to come into line with other subspecialties like gastrointestinal pathology and according to the intentions of the WHO? Keep smiling, Neil.
Thanks, Neil. I could have expected that question. I fully agree. We have been fairly conservative, but things may be on the horizon. So keep reading the blue books, Neil, and you'll find out.
Okay, thank you. So our next question is from Craig Bratton, who asks, a recurring clinical problem is the patient with a previous squamous cell carcinoma, often head and neck, who presents with the biopsy-proven squamous cell carcinoma in the lung. Anyone looking into using sequencing proteomics to differentiate metastasis from a new primary? Could AI compare the two and come up with a likelihood analogous to a Herder score? The treatment pathways are very different and often seem to be being made as a best guess.
Yeah, again, very good question, something that we encounter almost every day. I left that out of my presentation, but that's also something that we're working on because we do tumor clonality analysis with quite a low threshold on these cases. What we're trying to find out is what your minimum sort of genomic data set is, as it were. Can you suffice with a limited p53 mutation analysis plus some of the driver mutations, for instance? But that's definitely something that I think at the moment requires molecular diagnostics. Whether that translates to important morphological differences, I don't know. I think that's also something that we could address because we have a large data set with proven either secondary pulmonary tumors or metastasis based on the molecular outcome, and you could train a model to do just that. Yeah.
Okay, thank you. So our next question is from Graham Murray. Many thanks for an excellent talk. Do the lung cancer biopsies received in your institution have a standardized fixation processing schedule to minimize any variation both in morphology and molecular analysis occurring as a result of biopsy fixation?
Yes, I mean, yeah, as practicing pathologists, we know that this isn't always perfect. Depends on the time of day when we receive them, and whether we receive them at 5 o'clock on a Friday afternoon, for instance. So it's not completely standardized, unfortunately. We try to not fix the tissue too long, so definitely under 24 hours. And hopefully thereby also preserving some of the RNA, which we also need from the biopsies. but there is some variability. So that's from a few hours to 24 hours. Yeah.
Thank you. And so from a person who would rather remain anonymous, does your study cohort have genomic sequencing data? If yes, do you have any work looking at correlation between genomic, pathological, and clinical data?
It does. So we do have the sequencing data available. I think the problem is that for AI, you like to have large data sets, and as we mentioned, there's quite a large variability in underlying driver alterations. So I think the size of the data set that we have at the moment possibly doesn't lend itself to using the genomic data as an additional biomarker to the ones that we've already used. So anybody wanting to collaborate are always welcome because these models are hugely data hungry. Yeah, but that's a good point.
Thank you. So our next question is from Axel Firstberger, who asks, how strong is the influence of the data set presented to the AI training data for the performance? Can the performance be increased by adding regions of interest by an expert?
Yes, that again, very good question. So I think we try to stay pragmatic. So we wanted these models to be robust, and therefore we try to always include external validation sets. They're not always trained on a mix of data sets, but we always try to make sure that they work on external sets because, of course, people have other H&E stains. They may use different scanners and so on. So that's one of the parameters that we try to adhere to. And then the region of interest, there we've also been pragmatic. And yes, we still give the pathologist a role. You'll be glad to hear, Mark. But
Good.
we annotate the regions that the model should focus on, because otherwise you need to pre-train. You can use a pre-trained model to detect tumor areas. That's also possible, but we didn't include that in these studies.
Okay, thank you. So next, Marnix Janssen asks, thanks, Jan. What a wealth of research here. You briefly mentioned that pathologist-specific factors or traits drive PD-L1 inter-observer variation. I was hoping you could say a bit more to this, please.
Yeah, I was thinking that that might kick something off. So thanks, Marnix. This is a study from about 5 years ago, which we did in the Netherlands, and we had a sort of round robin of PD-L1 testing or PD-L1 stains, and had that assessed by a series of pathologists, and those were assessed by one of the sort of standard personality assessment methods, and there was a strong correlation with neuroticism, and I think it's the more optimistic and perhaps less neurotic, which tend to overestimate. So they give the patient the benefit of the doubt, as it were, which is not always correct, because patients with a lower PD-L1 expression may benefit more, for instance, from having combined chemo and immunotherapy rather than immunotherapy alone. But you can read it up. So it's I think it was I think Teodora Radonich was the lead author on this one. It's published.
Okay, thank you. So we have time for one last question. This will be the final question from Barry McGinn. There are lots of algorithm developers out there. When the time comes to implement AI, such as PD-L1 interpretation algorithms, into routine practice, how do you imagine which developers will be endorsed by professional bodies and why?
Yeah, I think that's the $1 million question. You can go to any conference and the exhibitors hall will be full of startup or perhaps more established digital pathology companies also offering their wares in terms of models. And I think it's all about trust. So it's trust of the community, and you need to build that trust through adequate validation procedures, having the right regulation in place, and I think also giving pathologists the opportunity to use the models in their own practice. and compare to their own assessments or potentially to other models before they're introduced. But I think that is definitely the next step that needs to be addressed. And I think pricing is also an issue because at the moment, for instance, in the Netherlands, we have no reimbursement for AI. So unless that is introduced at some stage, we also cannot afford to buy these sometimes quite expensive models.
Yeah. Okay, thank you very much for answering the questions, Jan. We've just hit 10 o'clock. In fact, it's 1 minute past 10 in the UK, 1 minute past 11 in the Netherlands. So I'd just like to finish the session by thanking Jan again for a really fantastic talk. Lots of data, lots of very interesting research work, a brilliant talk. Thank you very much indeed, Jan. That is really super. Thank you. And I'd finally like to mention that next month's March Pathology Grand Round will be given by Dr. Matt Clark. So that is something to look forward to on Wednesday, the 11th of March. Thank you very much. And that is all for this session. Thank you and goodbye.